Uh, Hi, I'm Katsu Yanaga, the chair of the International Relations Committee of SSAT. Welcome to the SSAT CBCD Clinical Case Management webinar, commemorating the inauguration of the Brazilian chapter of SSAT. SSAT has been active in global exchange of knowledge and techniques of digestive surgery, and Professor Daniel Jones and Professor Mark Cleary, the immediate past president of SSAT, initiated the SSAT Clinical Cases Management webinar last year, commemorating the establishment of the Mexican chapter. Following collaboration with SSAT members of Japan and Kuwait, this webinar is the fourth one and the second to commemorate the development of an international chapter of SSAT. I congratulate Professor Ulysses Ribeiro, Professor Daniel Dempsey, and Professor Luis Carneiro do Albuquerque, as well as other Brazilian colleagues for your effort in establishing the Brazilian chapter of SSAT. I need to emphasize that Professor Jean Nicolas Botte, our president of SSAT, has been especially keen to globalize SSAT through the development of international chapters. Following Brazil, international chapters are being developed in Italy, Germany, Kuwait, Japan, and many more to come, including countries in South and Central America. I really look forward to this webinar. I would like to take this opportunity to welcome you Brazilian surgeons to join SSAT. Thank you for your attention.
Thank you, Dr. Yanaga, for this nice introduction as a chair of the International Relations Committee. It's a very early hour in Japan with the Mount Fuji behind you and the sun rising, and we are so happy you're here. I'm sure we have a lot of listeners here at this webinar from various countries around the world. Welcome to CBCD members, the Brazilian Surgical Society. This has been a friendship now for many years with CBCD, and we are very grateful for all your contributions to SSAT. SSAT is dedicated to improve the care of patients with GI diseases through scholarship, education, and innovation, and we want to continue to do that, especially with our colleagues from South America. Brazil has been supporting SSAT, and a new chapter of the SSAT is being created, the Brazilian chapter of SSAT, under the leadership of Ulysses Ribeiro. Dr. Ribeiro, thank you for your conviction and your tireless effort. And in spite of your illness, we are so glad to see you. You have recovered and you are with us. We want also to thank Professor Carneiro, who is not here. He's been behind the scene here supporting this friendship. We were supposed to meet in person at the end of November last year when we had the last webinar with Brazil, and it's another webinar behind the screen. We hope that next year we'll join you on the beaches of Brazil. I want to now introduce also our two moderators. Dr. Wellington Andros doesn't need an introduction, an HPV surgeon, transplant surgeon, is a man of all seasons at the University of Sao Paulo. And Dr. Dempsey from the University of Pennsylvania, vice chair, they'll be moderating, introducing the speakers and the panelists. And I'll let you speak, Ulysses Ribeiro, Dr. Ribeiro, about the our friendship and on behalf of Dr. Carneiro and the CBCD as well. Thank you. If you can unmute, please.
Thank you very much, Dr. Valter, our president of the SSAT. My name is Ulisses Ribeiro, and on behalf of Professor Carneiro, who is the president of the CBCD, who is unable to attend this event, I would like to congratulate everyone for yet another webinar between SSAT and CBCD. Today we are launching the Brazilian chapter of the SSAT, independent of the CBCD, but which could involve all surgeons who treat digestive diseases. The CBCD is supporting this initiative. There will be joint meetings of the Brazilian Digestive System Week, SBAD, and other webinars in the first semester. We believe that this integration will lead to better medical practice and greater interaction between Brazilians and American digestive surgeons, the two largest digestive societies of the today. A Brazilian national chapter would allow surgeons members to increase the participation in national meetings and the DDW to share science, best practice, and fostering cooperation between surgeons of distinct hemispheres. I hope you have a very nice webinar, and I would like to pass the word to Wellington to give us some words about this webinar. Thank you very much again for everything.
Thank you. My name is Wellington Andraus, and it's really a privilege to be here in this webinar together with the SSAT and CBCD and our young chapter, Brazilian chapter here is born right now, and I think had a great future together. And I'd like to share the presentations, so I will tell you the name of the Brazilian presenters and moderators, and I think we will have the great webinar today and great future sharing the experience with Brazilian doctors and American doctors. And this we have many achievements with this initiative. So thank you all for this privilege. So I'd like to present our speakers. The first presentation, we have the presenter is Dr. Thiago Costa from the University of São Paulo. And as Brazilian moderators, we have Dr. André Siqueira from the Hospital do Coração, São Paulo, and Dr. André Montagnini from Gastroenterology Department of the University of São Paulo. In the second presentation, we have two moderators from Brazil, Professor Carlos Malheiros, full professor of the Santa Casa School of Medicine, and Dr. Ana Carolina Batista, also from the University of São Paulo. And in the third presentation, the presenter will be Dr. Marcos Kodama from the University of São Paulo. The professor, as moderators, Professor Paulo Kassab, full professor from the Santa Casa School of Medicine, and Professor Ulisses Ribeiro, also from the University of São Paulo. Thank you all for participation, and I'd like to thank you again for this initiative.
Thanks, Dr. Andreas. I'd like to echo your comments about how great it is for our two societies to form this chapter. I'm Dan Dempsey from the SSAT. I'd like to introduce our speakers and panelists. Our second case is going to be presented by Dr. Anne Lador from the University of Wisconsin. She's professor of surgery there and chief of minimally invasive surgery. She has an interesting foregut case and bariatric case, I think. Our panelists for the first case, Dr. Taylor Real from the University of Arizona, Tucson, where she's professor of surgery and chief of general surgery, and Dr. Harish Lavu from Thomas Jefferson University in Philadelphia, where he's professor of surgery and chief of HPB surgery. The SSAT discussants for the second case will be Dr. Dana Tellem from the University of Michigan, where she's associate professor and chief of the section of general surgery, and Dr. Daniel Jones, professor of surgery at Harvard Medical School at the BI Deaconess, where he's the vice chairman of surgery and chief of bariatrics and minimally invasive surgery. And our SSAT discussants for the third case will be Dr. Robert Roses from the University of Pennsylvania in Philadelphia, where he's associate professor and has a very busy practice in GI cancer and endocrine tumors. And Dr. Naruhiko Ikoma from MD Anderson, assistant professor at University of Texas MD Anderson, where he specializes in tumors of the pancreas, bile duct, and stomach, particularly with a minimally invasive approach. So we're very happy to have both all of our Brazilian and SSAT colleagues participate in this today. Thank you very much. Wellington, do you want to kick it off with our first presentation?
Yeah. So let's begin the first presentation. I'd like to call Dr. Thiago Costa to present the first case. And so Dr. Thiago, please.
Thanks, Wellington, for the kind presentation. I'd like to also thank the organizing committee for this invitation. It means a lot for me. I'm going to present some cases now, some interesting cases, and we're going to discuss with the panelists during the cases. So throughout the case, I invite them to make their comments and to say some words that we can get the most of it. I'm going to share my screen now. Just a moment. You can all see that? I think so. Yeah. So I'm going to start with further delay my presentation. This is the clinical cases discussion about pancreatic cystic lesions. My name is Thiago, as I was presented before, and I'm from the University of São Paulo. So the first case, it's a female patient, 51 years old. She is asymptomatic, and she was done a ultrasonography with a cystic lesion on the neck of the pancreas tail. At her physical examination, a BMI of 23.4 and no other findings. Labs, we only had the CA 19.9 of 18 and the CEA for 2.4. No other labs were found in her history. So with the ultrasonography done before, we did a CAT scan that you can see here, and the report was a cystic lesion of 3.4 centimeters, homogeneous, and no communication to the main duct. I'd like to invite any of the panelists to make a comment on this CAT scan and what would you do if you do MRI or any other kind of examination?
Dr. Real, do you want to comment on what you think the appropriate workup would be here?
Sure, I'm happy to start. So I think the cross-sectional imaging we have is fine. I don't think I would necessarily add an MRI. I'm looking at a couple things. I'm looking for high-risk stigmata and worrisome features on this mass. The only worrisome feature I see present is a cyst larger than 3 centimeters. However, I don't see any enhancement of the cyst walls. I don't see any main duct dilatation. I don't see any change in caliber of the pancreatic duct. The CA19-9 levels are normal, et cetera. I don't have 2 points in time, so I can't really comment on the growth rate of this. But given the size, to better characterize it, I would probably order an EUS to just get baseline, to get cyst fluid aspiration, to understand more about it. So that's where I would start, and I'd be happy to hear what the other panelists say.
I would agree completely with Dr. Rial, and I'm always interested in if there's any family history of pancreatic cancer or pancreatic diseases that sort of affects my perspective. And the fact that it is over 3 centimeters, I think indicates that it would warrant an further invasive test such as an EUS. And so I would be in agreement with that.
But we don't have it clear, our differential diagnosis here, if we have a branch side IPMN or non-mucinous cyst, or even a oligocystic serous lesion. So maybe in this situation, the endoscopic ultrasound could give us a clue and even analyze the fluid cyst, as Dr. Taylor said. Maybe this is an important step, since in this different scenario, the precise diagnostic is important.
Yeah, I would agree 100%.
I would say the same. I think the very important thing here is about the size. I think it's a lesion with more than 3 centimeters. I think the endoscopic ultrasound is very important for the differentiation of the diagnosis.
The only other thing I would say about this patient is she's 51, so she's relatively young, and the location of the cyst is problematic just in terms of, being right at the neck. It just makes any kind of surgery different. So really understanding what this is going to help us in the management.
Okay. The patient did an MRI, and with no further information, you were all right about that. So we did an EUS on this patient, like the panelists said. And the EUS showed a homogeneous cyst with no septa and no communication to the main duct. The fluid aspiration did a CA of 3, glucose of 80, and amylase of 10. That's the only examination we had at that time. Would you comment on that?
Well, it's all very favorable to suggest a benign lesion, and in a woman of this age, you would think number 1 would be a side branch IPMN, number 2 would maybe be an MCN, and this fluid analysis does not really correlate with those. So I wouldn't say the cyst looks classic for a serous cystadenoma, but there is a variant of an oligocystic serous cystadenoma, so you wonder maybe about that. But my general impression on this in an asymptomatic woman whom I'm meeting for the first time is I probably would not intervene on this, but I'm curious what my colleagues think.
I'm very comfortable with the results of the US, especially because of the level of the CEA, and I agree that I just will follow this patient.
Dr. Rial, you alluded to the rate of growth, or that you didn't have any previous imaging. How would that factor in your decision-making at this point? Suppose you did have an image from a year ago, and this was quite a lot larger now than it had been then.
If it was rapidly enlarging, it would definitely change my view of things. In the setting of a low CEA level, which suggests this isn't a mucinous lesion, it really leans toward a benign lesion. And you could argue if we knew for sure that this was a serous cystadenoma, then we wouldn't even need to follow it. So I would say in any patient, an indication for surgery, if I knew for sure is a serous cystadenoma, would basically be if that patient was symptomatic. or if it was rapidly growing. But typically, and I don't know, I can get opinions from others on the call. If I'm very sure something's a serous cystadenoma, I don't necessarily follow it for a significant length of time. In this, because it doesn't look classic for that, I would probably get interval imaging and make sure this is stable over a period, and then probably stop following it. But I'm happy to hear what others have to say.
Yeah, I couldn't agree more with that, because this is the first, it is an incidental finding, the first exam of these patients. Biochemical analysis indicates there is not a mucinous lesion, and even glucose is over 80. And as you see in the first image, we have a very thin wall of the cyst, no septum inside. Maybe we are facing now oligocyst, cystadenoma, serous cystadenoma. So in this situation, we could watch and wait this patient. So I don't see indication for further aggressive procedures here.
Okay. So we did watch and wait. And I'd like to ask the panelists for how much time would we wait, or for how long would you repeat some kind of examination? Would you repeat an EUS or a CAT scan or an MRI? What would be the best imaging to do?
For me, in the setting of a non-mucinous lesion, I would probably follow this at 6 months and a year, and then I'd probably stop if I really thought this was a serous lesion that wasn't growing. If it was a mucinous lesion, my time to follow up would be shorter.
Yeah, I mean, the cyst fluid analysis was very reassuring on this. I would probably see the patient back in 1 year. And because she had had a CT scan, I'd probably get a complementary test of an MRI, MRCP on the second imaging test.
Andrea?
I do the same. I think because of the levels of the CEA, I'll see the patient again after 1 year with MRI probably.
Yeah, but as we have only one image, one test, this is the first one, and it has 3.4 centimeters at the diagnosis. I'll check it in the 6 months.
Okay.
Even CT or MRI, whatever.
We did follow up with a CT scan for 1 year, and the patient walked off our hospital for another year. So she came back 1 year later, and then another year, and you can see here it's growing. So at this time she is symptomatic. At those times she wasn't symptomatic. Would you comment on the findings of the CT scan?
Well, we can see clear the growth of this lesion, but you mentioned she has symptoms related to the cyst, or I mean, like pancreatitis or compression, or
compression of the stomach,
bloating.
Yeah, bloating.
Early satiety, maybe.
No, cysts growth. This is the main problem of them. They grow, and they can become symptomatic, and the usually symptoms are related to compression. Mm-hmm. So maybe we are facing a growing oligocyst serous lesion.
Yeah, I mean, we sort of talked about this in the beginning. I said, if this was growing rapidly and she was symptomatic, those would be indications for operation, even in a benign lesion. I would tell her, I still think it probably is. This now we've been following it for 3 years, and I would offer. I can't see all the images, but it looks to me like this is certainly to the anatomic left of the portal vein SMV confluence. So I'd offer a distal pancreatectomy.
Yeah, I would agree with Dr. Real as well, and Dr. Montagnini, that the presentation is classic for an enlarging. It doesn't look like a serous cystadenoma. That's the only thing that's a little bit odd. It doesn't look like it, but the growth and the symptomatology of early satiety is one of those things you see, and probably all of us have encountered patients who come in with a 12 centimeter or a 15 centimeter serous cystadenoma that can be challenging operations if they're around the portomesenteric area. And so I would recommend this be removed at this point and with a distal pancreatectomy.
And because it doesn't really look classic, it's another reason for me to remove it, Harish, you know?
Right, exactly.
I totally agree with the panel. I think that it's not a typical lesion. That's one very important point. The second is, I think the growth is quickly, rapidly. I think three years for this size of lesion is worry about. And the third, sorry, is about the symptoms. If symptoms, I think that the surgery has indication. And look the location of the tumor. I think that distal pancreatectomy is the best.
Should we include from principle splenectomy, or if we are considering a benign lesion, should we preserve the spleen? What's your opinion on that? I understand we now indicate the surgery. So which one should we perform? Consider a central pancreatectomy, distal, or including or not the splenectomy in this situation? Imagine we are not facing a mucinous lesion.
Yeah, my own view on that is that the lesion's a little bit large now to do a central pancreatectomy. You know, you could probably preserve the tail of the pancreas, I guess. But in my practice, in an adult patient, a middle-aged woman, I just do a distal pancreatectomy and splenectomy and be done with it. But I'm curious if you guys dig out the splenic artery and the splenic vein and follow it all the way along and preserve the spleen. I'd love to hear that.
I'm kind of with you, Dr. Lemou. I not that attached to any spleen. Having said that, we can make an argument to preserve it. I wouldn't do a central pancreatectomy. I think it's not a good operation. And again, with that enlarging, plus, with it enlarging so rapidly and not looking classic, I probably recommend splenectomy, but certainly one can make an argument to preserve the spleen.
Okay. I think that a central pancreatectomy could be an option. The decision should be done intraoperatively. I think that if you have a large tail to be preserved, I think central pancreatectomy will be an option.
If she were pre-diabetic or had a situation where you were worried about her glucose intolerance, would that push you more towards doing a central pancreatectomy?
For sure.
Taylor or Harish, do you think?
I don't know. I almost never do it. It kind of doubles the risk of leak. It's certainly a conversation that we would have. I certainly talk about that and offer it, but I probably would, in this case, I would probably push for a distal.
And should we to decide that before? So if we are facing a pre-diabetic patient and we want to preserve the pancreas tail, should we again perform a biochemical analysis to make sure it's not a mucinous lesion?
I think that would be mandatory if you were not going to do the full resection. You'd have to either do it pre-op or at least intra-op, do the central, send it to path, have them tell you what it is, and determine at that point. Occasionally, a patient like this will come along and they're already a diabetic and they're already on insulin or something like that. And in that case, my view is they're on insulin. They're just going to give themselves a higher injection. And so I wouldn't do the central in that case. The centrals that I've done have almost always been in younger patients. That's been my take on that.
Okay.
What happened to this patient?
Yeah, we heard you, and we did a laparoscopic distal pancreatectomy with splenectomy, and it was a serous cystic neoplasm. So that's the fluid that came out of the cyst, and that's the final view.
Maybe the symptoms are related to this. The fluid is very dark, it's dark, brown. So maybe we had a former bleeding inside.
That could be. Yeah, you're right. It could be.
And how many? The length of the distal pancreas, it's about 6 centimeters. So it's the limit, maybe, to perform a central pancreatectomy. It's very interesting.
Did the operation help the patient's symptoms?
Yeah, it did. The symptoms went off.
Or change the symptoms.
Other thing. Like,
Is she diabetic now, Thiago?
no, she's not. She's not. She's all fine.
Okay.
Could you comment on how you manage the pancreatic stump? How did you divide the pancreas and how did you control the stump?
Okay, in this case, we use on the stapler. We use the blue load of Agicom, and sometimes we use some stitches too. In this case, we didn't use it. The patient had a fistula that was managed about 2 months with the drain, but now she's very fine and no problems occurred in posterior.
That would be an interesting question to ask all of our panelists, how they manage the pancreas and a distal pancreatectomy. The leak rate's 20% or so, I think. Does everybody handle it the same way? Dr. Rial?
So, in this kind of pancreas, I usually will try to staple it. It kind of depends on the compression I can get with the stapler and different things. But if I can compress it, I'll staple with a reinforced staple load and generally leave a drain. If it's a really thick or really hard pancreas that I can't compress with the stapler, I'll just divide the pancreas and I'll over sew it, usually in 2 layers. I do like a mattress layer to compress the duct and then an over layer. If I staple and I feel like it tears, I'll also over sew it, but that's generally my practice.
Dr. LaRue?
Yeah, I'm pretty similar actually. I don't do the same thing in each case. If it's a soft pancake type of pancreas, the stapler is just a beautiful mechanism. And I use the seam guard and the blue load on an echelon. It works beautifully. Now, the cases where it's a round pancreas, it's a more firm pancreas, the stapler is not going to work, and I divide it with cautery, identify the pancreatic duct, ligate that, and then mattress sutures. But as Dr. Dempsey said, it's so frustrating because no matter what you do, and it's amazing you said 20%, because that's our leak rate at Jefferson from distal pancreatectomy is exactly, it's 20. And it's just incredibly frustrating. And I've played around with different things like vascularized falciform patches, gastric serosal patches, all kinds of different things. Different ways of ligating the main duct through the parenchyma. So if someone has a much lower leak rate, I'd love to hear any other techniques.
Dr. Montanini, what do you use? How do you do the stump?
The strategy for pancreatic section is pretty much the same. If the pancreas can be compressed, safely compressed by the stapler, we do this. We compress very slow. That's the point. We use slow compression to the end. Sometimes it takes more than 1 to 2 minutes to compress the pancreas, avoiding the fracture during the section itself. In case of large, hard, round pancreas, I do not perform the stapling. I cut the pancreas and oversew, but in one single layer. And if I can find the duct, I isolate it, make a knot around the duct, and I use figure of 8 proline for 3 or 4 zeros proline to hold the pancreas, and I usually drain. So despite the discussion, if the drain gets the infection inside and leads to the fistula, or the fistula itself will come with or without the drain, we prefer to put a drain because we don't have easily access to interventional radiologists to drain intra-abdominal fluid collections, peripancreatic after surgery. It's a very risky procedure, so we prefer to drain. And our distal pancreatectomy fistula rates is a little bit higher, 25 to 25 to 30%, depends on the period we are, the range time we use. But that's the main situation. If fits for a stapler, we do a stapler, and we decide the load. If not fits, we prefer to section and oversew and put a drain.
Dr. Mateus, do you agree? Any comments?
Yes, I agree. I do exactly the same. The only thing that I do is sometimes I decide that the type of stapler I'm using depends on the soft of the tissue. And sometimes I use like a black or blue cartridge. It depends on the size of the pancreas. And even if I use the stapler, sometimes I put some stitches where it's supposed to be the duct. And if the pancreas is very tender, I use the very like a brown stapler. And if it is very hard, I just section the pancreas with like a ligature or with a incision, identify the pancreatic duct and put some special stitches on it.
Dr. Montanini mentioned proline. Does everybody agree we should use a permanent monofilament on the pancreatic stump?
Yes, I do the same.
You know, I actually use, I ligate if I'm sewing it, I ligate the pancreatic duct with a 4/0 silk figure of 8. And then the mattress sutures, I use a 3/0 Vicryl. Okay. One thing Dr. Montanini mentioned, which I think is really, really important, is this slow compression issue. And I've become like obsessed with this, where I now use I'll begin with a bowel clamp and I slowly compress it for 3 minutes. And then I get the stapler and then I slowly compress that for 2 or 3 minutes and then divide it. And I don't know, it's really has to do with the pancreas itself, you know, more than the stapler or anything else. If you can get it to be pancaked and the staples can form, it's a very durable closure. And if you can't, then it just doesn't work.
I know one surgeon who was very attached to the CO2 stapler for the pancreas, thinking that the application of pressure over time was more consistent with that device. I don't know if there's any evidence of that or not, but well, that was a very good discussion. Any other issues that we should bring up on this?
Reinforcement on pancreatic section.
I use that seam guard. It's made by Gore, and
yeah, I know.
I use that on the blue load stapler.
Yeah,
Taylor, do you use that?
We have Covidian staplers and they come like reinforced. So yeah, I use a seam guard.
I hardly ever use it. The evidence is it's weak that in the prevention of, I believe that it's weak to justify the routine use on that.
I use only the stapler.
Yeah.
Okay, that was a very good discussion. Thank you very much, Dr. Costa, and thank you for the panelists. It was a great discussion. Appreciate that. Wellington, would you like to introduce our second case?
Yeah, I think I'd like to, let's move on for the bariatric and metabolic surgery. So I'd like to call Dr. Leader to present our next case. And we have our panelists. We are ready to introduce them. So please, Dr. Leader.
Yep, can you see my slides? Okay, great.
Yes.
Okay, perfect. All right, so I have a very interesting patient. This is a 60-year-old woman. She's 5'6" and weighs 331 pounds. That puts her at a BMI of 55 kilograms per meter squared. And she was referred to our general surgery clinic for the evaluation of GERD and a hiatal hernia. She does have a fair amount of comorbidities, including diabetes, reflux, hypertension, COPD, coronary artery disease, depression, and anxiety. Her past surgical history was significant for a TAH-BSO with some sort of para-aortic lymph node biopsy for ovarian malignancy in the 80s. She wasn't really able to give me very much detail about that operation. She also had an open cholecystectomy in 1989. And you can see on her meds that for her diabetes specifically, she was on metformin and over 70 units of insulin per day. She was also on BID, PPI, sucralfate, Zantac, and ondansetron for her reflux. And oops. Just of note, she had been living in China as a missionary for the prior 10 years and hadn't received any real regular medical care. And so when she came back here to the United States, she was really sort of in pretty poor shape. And for her history of present illness, reflux symptoms for many, many years recently worsened. At this point, she was vomiting daily with very severe odonophagia and dysphagia, and had lost 30 pounds over the past 6 months because of her upper GI symptoms. She had never had any hematemesis or melena. And she had just been admitted to the hospital right before she was seen in my clinic, where she was noted to be tachycardic. Her hemoglobin was 7. She got 2 units of packed red blood cells, and they did an EGD when she was admitted, which showed a moderate sized hiatal hernia and LA grade D esophagitis. You can see the pictures from her EGD from that admission. At that time, she was started on a PPI, the twice-a-day PPI and the Carafate, and then she was referred to GI medicine and also to our clinic for further evaluation. So I guess I'll leave it at that and see what our panelists thinks we should do at this point. Any further workup, or what would you all recommend at this point? Dan, Dana?
Well, it sounds like we're going to get her out of the general surgery clinic and into the bariatric surgery clinic.
Luckily, when she's in my clinic, she can be in both. Any other workup that you would want to get at this time, or what would you want to do?
Oh, I agree with the PPI and reevaluate after stabilization. And for the moment, or general surgery, I would not think at this moment in bariatric surgery, but of course, bariatric team has to start the follow-up of this patient.
So are you saying you'd recommend just continuing medical therapy? Is that what you're saying?
For the moment, with hemoglobin of 7, unstable, tachycardia, and for the moment, only stabilization and maintain the PPI and reevaluate after complete stabilization.
So it's interesting, Ian, because it's always interesting to get these patients, and I think it brings up the nice point, divorcing when do we do an operation for reflux versus when do we do an operation for a hiatal hernia. And, I think reflux is like a completely different path. But when we think about, do we need to operate on a hiatal hernia? I always kind of use three key things in my head. One is, shortness of breath or inability to breathe, chest pain, a lot of times they come in with P's, or cardiac issues. And third is active bleeding from Cameron's ulcers, which is presumably is. So you have a woman who's had poor health care with a lot of metabolic syndromes, who's coming in with a bleed, who you've presumably stabilized from all of those things with active Cameron's ulcers. And so this is somebody you'd want a hiatal hernia repair. I think that you'd want to proceed with a hiatal hernia repair, once you've kind of made sure that they're teed up. I think the only part of the part that made me a little concerned was the 30-pound weight loss, within a couple months, which you don't typically see, even with the hiatal hernia with regurgitation. So it may be worth, especially given her previous history of ovarian cancer and this periodic biopsy, to rule out other potential sources for malignancy or issue. But I think for someone like this, I would consider moving forward, assuming that's negative, with a hiatal hernia repair to treat the bleeding essentially, and then with a bariatric surgery to treat holistically for the metabolic conditions.
Well,
Planning on the bariatric surgery in the future after clinical improvement, I would also do an image exam like an X-ray or abdominal and chest CT. Here in Brazil, we like a lot of esophagogram to analyze hiatal hernia and plan the surgery, the real size. We can see it better than with an endoscopy.
So Dana, are you saying that you would by the time I saw her in my clinic, she obviously was stabilized and she had gotten, blood transfusion and was doing better. She was having very, very significant odonophagia, presumably because she's got grade D esophagitis, and it was just really painful for her to swallow. And I was pretty sure that that's what was contributing to her weight loss. They did do biopsies and those were negative for malignancy. But are you saying that you would offer this patient just a paraesophageal hernia repair? With
the
BMI 55.
pass. So first, I think that first decision note is, are you going to do surgery or not? And in this patient, I would do surgery. And then the second decision note after, you're going to fix the hernia. And then the question is, and what? And what are you going to do for that second part of it? So given her metabolic picture, once I've committed to thinking she needs a hiatal hernia repair, my preference would be to also do it with a Roux-en-Y gastric bypass, assuming she doesn't have a frozen ab, all the types of things that could have happened from her previous surgeries.
Would anyone of the panelists offer this patient just a paraesophageal hernia repair with some sort of a fundoplication at a BMI of 55?
No. So the fundoplication part, you're not going to want to do, but you might fix the hernia as a stage procedure if you thought it was big and complex when you got in there, put in a G-tube and come back later. My partners did that recently on a patient. They thought they were going to take care of the whole thing and got halfway through and put a timeout on it. So if it was a giant hiatal hernia, it was more than you planned on, you might do it as a stage procedure. But I think most people are going to take this on as a gastric bypass and repair the hiatal hernia.
And also, as this patient has super obesity, BMI over 50, maybe some preoperative weight loss could improve in the safety of the procedure.
Yeah, she was losing weight on her own.
Yeah.
From not being able to eat.
And could I ask the panelists if there are any rabid believers in esophageal lengthening procedures, either collis or wedge fundectomy as part of large hiatal hernia repair, and if they sort of forget about that part in patients that need a bariatric operation.
So I'm going to make a super controversial comment as a person who has a lot of patients who don't want a Roux-en-Y gastric bypass, which is, what is a gastric sleeve if not a large collis, right? And so the question is, having to do that. I think sometimes for these large hiatals, if you get your dissection high enough up all the way up to the aortic arch, very rarely do I need to do a collis or a wedge gastroplasty if I can get all the way up to the dissection, release everything, and get that good 3 to 4 centimeters of intra-abdominal esophageal length that's not reflecting back. But if I can't do that and they have a foreshortened esophagus from chronic reflux or some of the other conditions that happen, then that patient I'd consider doing a collis in.
Okay, all right. Well, so what I talked to this patient about was basically what most of you have already said, talking about take her into the operating room to do a repair of her paraesophageal hernia and a concomitant Roux-en-Y gastric bypass. That was my plan. Basically, before doing that, we did get some additional workup. So just on exam, she had this sort of pretty extensive midline laparotomy incision, and then of course the subcostal incision from her open coli. Her hemoglobin A1C was 7.5. She still was pretty anemic even after her blood transfusion and even being on iron, so her 8 and 27. This is just a snapshot from the barium swallow that we got from her. I tried to get the, they didn't, for whatever, capture the cine part of it, but I wanted, she did have a fair amount of esophageal dysmotility as well. And you can see she's got a decent sized paraesophageal hernia. And then given the fact that she was having so much nausea and had been diabetic for so long, we also got a gastric emptying study. And that was mildly delayed with 17% retained at 4 hours. The problem came up with her is that because she had been out of the country for so long and was on medical assistance, is that they basically refused to cover the bariatric part of her operation at all. So what would you guys do now? I mean, I had multiple phone calls with peer-to-peer reviews with everyone. Basically, absolutely, they refused to do that. What would you guys do in that scenario?
Would they cover the hiatal hernia repair? Because
Oh,
the
yeah.
hiatal hernia repair doesn't necessarily include the reconstruction.
They would pay for the para, but not for the concomitant bypass, which is what I wanted to do.
Would they deny the para payment if you did the bypass?
They just would not cover the bypass, period. That was not a covered benefit and they wouldn't cover it at all.
No, but I guess what I'm saying is sometimes we've gotten around that, at least from an insurance perspective, because if you're billing it as a hiatal hernia, then it doesn't really matter what you can do. You know, if you do the reconstruction, whether you put a G tube in or do a wrap or do a bypass, it's the same CPT code.
Oh, yeah, they're pretty strict about that. Some of my partners have tried doing that in the past, and they basically just don't cover any of it. So I was instructed not to do that. Dan?
I mean, if you can't do the weight loss aspect, I'd fix the hiatal hernia and do a G tube. Maybe think about turning that G tube into an the Asper tube later.
How about my Brazilian colleagues? What would you guys do if you couldn't do the bypass at the same time?
I don't know, maybe fundoplication, but knowing that she'll have a recurrence in short time. It's a very difficult situation. Here in Brazil, even in the private insurance, we could do, as Dr. Dana said, we could do a bypass for reflux, not naming as bariatric.
Yeah, yeah, they're very strict in Wisconsin. It's kind of a hard thing to get around.
Yes, I agree. It's very difficult because a fundoplication is found to recurrence is almost mathematic, the recurrence. Only consider a fundoplication if the patient could lose a lot of weight in preoperative. Otherwise, it's very difficult. Anyway, she has to start losing weight more than is losing right now. And you have to think after what to do. But I agree with the proposition.
Yeah, so she was really just pretty miserable. I mean, she just could not eat. She was still, you know, obviously ongoing bleeding. Her hemoglobin would not get up above 8. So I really felt forced to take her to the operating room. So I ended up taking her to the OR, and I fixed her hernia and did a toupee partial fundoplication. As you mentioned, Dana, her abdomen was completely hostile. It was so difficult. I don't even remember how long it took me to do this case. It was really, really hard case. And I didn't feel good about it because, like everyone said, I pretty much knew she was going to recur. She did do well initially. I mean, her hemoglobin improved. She didn't have as much dysphagia. She was able to stabilize her weight. She still had a fair amount of nausea, presumably from her gastroparesis. But then 6 months later, as you would predict, she just had recurrent GERD symptoms with dysphagia again. She got admitted to the hospital several times for PO intolerance. They did another EGD, and then you can see that she had, grade D esophagitis again. Her RAP actually looked pretty good actually on her esophagram, but here's somebody who's, been on maximum dose medical therapy, had the definitive anti-reflux operation and is still really, really pretty sick. So what would you do now?
Did you say if the hernia came back?
On her esophagram, she really didn't look like she had a big hernia. It looked like her RAP was fine, and she had a little bit of a tiny little hiatal hernia on the esophagram. Not terrible.
And she didn't magically switch insurance projects.
Well, no, but I can tell you, Dan, that now that you just mentioned earlier that I should have put a G-tube in her, it would have been incredibly helpful, because we ended up having to put an ND tube in, and for BAPA feeds, because she could not eat at all.
So that was one of the things I was going to ask you, Anne, is like weighing the decision of like a wrap versus, maybe like a 2-point PEXI. Because I know some people PEXI in general, one around at the angle of his, and then with the G tube versus a wrap, and what your thoughts are on that.
Yeah, I mean, in retrospect, I guess, it was such a difficult case. I just didn't want to think about having to come back. So I tried to do what I thought was going to help her the most, because she was so symptomatic. But I do, in retrospect, wish I had put a G-tube in her for sure.
And could we get the panel to weigh in on mesh at the hiatus in patients that they think have a high recurrence risk?
Yeah, sure. I'd love to hear what you guys think about that.
In this case, oh, sorry.
No, that's good. Go ahead, Dr. Moyos.
In this case, in this moment, I will propose for the treatment, a diagnostic, a recurrent reflux disease, severe reflux disease, and I will propose a gastric gastrectomy and gastric bypass for the treatment of reflux disease, recurrent reflux disease, not as a bariatric surgery.
Yeah.
Yeah, I think you now have a case of failed treatment, and the next step would be gastric bypass.
Agreed. What do you guys, any of you guys, I did not use mesh at her hiatus because I was able to close her diaphragm. Would anyone here use mesh routinely to close the diaphragm in a patient of this size or with this hernia?
How big was the defect that you saw?
She had like probably half of her stomach and her chest, but I was able to get her diaphragm closed.
So 5 centimeter defect, 10 centimeter?
Yeah, like 5 centimeters probably.
And did it come together without tension?
Yeah.
And the G junction was intra-abdominally?
Yeah, not as much as I would have liked, but yeah.
There's probably no need for, and you use pledgets?
No, I don't never use pledgets. I now use a running VLOC O non-absorbable suture to close the diaphragm.
So I'd use pledgets, but other than that, I would not use the mesh.
Anyone else? In Brazil, are you guys using mesh routinely or?
No, most of the surgeons, I don't think so. Especially in this case, there's such an evidence that the recurrence is related to the high BMI and not to the hiatal hernia defect.
Yeah.
Yes, same position.
Yeah. So that's what I did. I called everyone back in the authorization office for medical assistance, and I basically said, listen, she's failed therapy, she's got, can't eat, and I need to do this as a definitive operation. And they did allow that and allowed me to move forward with the gastric bypass. So I scheduled her for that. So I took her back to the OR, and it was so awful in there. I literally could not even find any plane between to get into the chest at all. I mean, not in the slightest. So I ended up I even called in one of the thoracic surgeons to the operating room, and he and I, looked together. He scrubbed in for a little while, and we basically decided that we were just going to abort the operation at that time and plan to bring her back to the operating room for a combined abdominal and thoracic approach. And in the meantime, that's right, kind of when COVID hit, so we couldn't do her surgery right away anyway. So I put a Dobhoff tube in her, kept her on the maximal therapy, and then I think 4 months later took her back to the OR, where we did a basically open abdominal and open thoracotomy. We were working simultaneously. The thoracic surgeon was in the chest, I was in the belly. We were worked together until we were holding hands, so that we had finally able to free everything up. And I mean, her esophagus was so scarred. It was like hard. It looked like a baseball. It was like so contracted down. So we ended up doing partial gastrectomy, partial esophagectomy, and a Roux-en-Y esophagojejunostomy with the Roux, pretty far up in the chest. And then I did put a feeding tube in the remnant this time around.
And it looks like your hernia came back because you repaired it again.
Yeah, it was that wasn't really the big thing. The problem was primarily that it was just so adherent between the hiatus and her stomach and wrap. And anyway, so that was a pretty difficult operation, but she actually did reasonably well. This was her post-op, post-op day 2 or 3 upper GI. We did that just to rule out leak, and you can see that the Roux limb is pretty far up in there, but that all looked fine. And now 6 months later, I finally have gotten her G-tube out. She's eating without any dysphagia. Her nutrition has improved significantly. She's down to 168 pounds, so she's lost a total of 163 pounds. From when I first saw her. BMI is now 25. Hemoglobin A1C is 5.3. She's got no diabetes meds whatsoever, off insulin, off oral hypoglycemics, and her hemoglobin is now back to normal, and she's not even taking any oral iron. So after all of this, she's actually finally done really well. I kind of just wish I'd been able to do the bypass the first time around and not have had to go through all of that, but it was a really challenging case. I don't know.
Does she have reflux?
No. Nope.
So the gastric bypass worked.
The gastric bypass worked, which is what I had wanted to do the first time around. I kind of wanted to call them back and say, if you had just let me do the right operation the first time, you wouldn't have had to pay for 3 operations in total.
And why did you leave the distal gastric remnant in place?
Oh, she was so malnourished at the time that I finally operated on her. And I was afraid that she would I was really afraid that she might have a leak, obviously. So I wanted to provide her nutrition post-op, and then B, if she had a leak, that would be some way for us to be able to feed her. And she didn't get a leak, thankfully.
Dr. Batista Donis, any comments?
Yes, I want to congratulate Dr. Leader. Yes, a very, very difficult case. And I want to congratulate you for aborting the bypass surgery. That's the main, the patient is alive and well because of this decision. This kind of decision is a very difficult decision to abort a surgery in that time, but was the main point of the patient survival was to aborting that kind, at that time, the surgery. Congratulations. Oh. Very difficult, very interesting, and very difficult case. And you have to also to congratulate the insurance.
Every time.
Yes, yes, they deserve a prize.
What is the insurance environment for bariatric surgery in Brazil? Is it an issue or not at all?
I think it's a little better than this case. But usually the insurance authorize the surgery. But in some cases, they invent every kind of excuses, but in most of cases, the insurance can authorize the surgery.
Yes, congratulations, as Dr. Malheiro said, a very interesting and challenging case. I think, especially in public healthcare here in Brazil, we have a lot of patients like this that were without treatment for many years and arrive in a very poor condition, clinical condition. So sometimes a staging procedure is the best we can do to save their lives. But as he said about the insurance, most of the times, yes, they're very bureaucratic, a lot of paperwork, but probably in the first case, they would authorize the gastric bypass, not as bariatric, but as reflux treatment. So we could do the same surgery, just use a different name.
Yeah.
So, and if the patient had a slightly lower BMI, much less severe reflux, but had a hiatal hernia, but had reflux, are you okay with proceeding with the sleeve?
I usually don't do sleeves for patients who have reflux. I most, unless there's some really other reason why not to do a bypass, I almost always will do a bypass for a patient who has reflux symptoms.
Yeah, and I almost always am doing a sleeve for patients with reflux. And when I fix the hiatal hernia, the reflux goes away and the weight comes off and the reflux goes away. And so it's not always so obvious that you need to jump into the gastric bypass, in my opinion. Dana, what do you think?
My preference is to do a bypass, but I don't, I'm not prohibitive about it. If the person refuses a bypass and there's no evidence of a motility disorder, I'll do a sleeve. I think when we get into trouble with sleeves, it's probably more undiagnosed motility issues than anything else. And when we look at sort of the long-term data, you know, what you see is even those who develop reflux, less than 4% need conversion. So I'll give people a chance, because chances are, even if they develop some symptoms after, it can be medically managed, and probably, and from my anecdotal experience, to your point, Dan, they typically get better, you know, unless there's something weird going on. But in this patient, it seems like she also had a motility issue, probably some gastroparesis from her diabetes. And I don't care so much about the reflux, but the gastroparesis and the diabetes, that's what would tip me over the edge. But I usually prefer bypass, but not prohibitively.
So are you getting screening endoscopies on all your pre-bariatric patients? Any of you, like routinely?
Yeah,
Yes,
here in Brazil,
yes.
we already did it preoperative for every bariatric patient. And now with recent data showing Barrett's esophagus and very prevalent GERD after sleeve, we do every year in post-operative.
Oh, so those are, you're following the IFSO recommendations that just came
Yes.
out. Yeah, yeah.
Yes,
Mhm.
yes, I agree.
But it's curious because we have patients, I have follow-up for 10 years, 5 years of sleeve, no Barrett's esophagus. A lot of GERD, yes, but no Barrett's. It's curious.
Do you keep them all? Do you keep them all on PPI or just
no, just
as needed?
asymptomatic.
So I have a couple patients who had short Barrett's, had a sleeve, the reflux went away, and the Barrett's went away.
Good.
Are you doing endoscopies on everyone pre-op, Dan, or no?
If they're symptomatic in any way, yes. If they're completely asymptomatic, probably not.
If you were planning on doing a sleeve on someone and you saw they had Barrett's, would you still do a sleeve?
I have, yes. So we've done it and we've seen it go away. If it's long and it's severe, then no. If it's short, and this is in consultation with a special consultation we do with our GI service, who sees the whole spectrum regularly, we'll proceed. So the GI guys have only seen one patient who they said don't do it. And so we've done it on a number of folks and we're tracking them closely. And again, especially if you have a hiatal hernia and you fix it and the reflux gets better and the weight comes off and the reflux gets better, they're actually doing pretty well. So not all Barrett's is the same. And there's a few of us out there who are offering a sleeve with the understanding that if they go see 99.9% of anyone else, they're going to get a gastric bypass. So that's part of the consent. The standard of care is to do a gastric bypass. But if they don't want a gastric bypass and they want a sleeve and it's not severe, and they understand that they would get a gastric bypass if that progressed, potentially, yes. But right now we haven't converted anybody to anything who had a Barrett's preoperatively. So we're going to keep tracking it, and we'll see what it shows.
And do you know?
And by the way, that we have patients who've had gastric bypass and have gotten Barrett's. So it doesn't mean if you get a gastric bypass, you can't get Barrett's.
Do you know what your conversion rate is, sleeve to bypass for reflux, or have you not tracked that?
Oh, it's very, very small. A handful of people, and most of those handful were people that were done elsewhere.
Are you doing endoscopies, Dana, or just
selectively pre-op, but I scope everybody intra-op. So I'd say everybody at some point gets some type of endoscopy. But again, reflux can be silent. So, we toy with this idea of, should we just be scoping everybody before, but we have so many constraints on our system that would add sort of unnecessarily additional barriers and time, and then people can't get their requirements done in time. And so we've kind of settled on this hybrid of anybody who's at higher risk or anybody whom we're going to do a bypass, since we're going to already exclude that stomach and never see it again, should at least probably look once, or who've had symptoms or family history or, any of those things we'll scope. In a perfect system, it would be my preference. We just don't quite live in that system right now.
Agreed.
Agreed.
All right. Well, thanks, everyone. That was great.
Thank you, Ann, and thank you, all the panelists. That was an excellent discussion.
Yes, thank you.
Thank you.
Let's move on now to our third case. Let's move right into that since we've already done the introductions.
Yeah, Dr. Marcos Kodama, please, could you start the presentation?
Hello, my name is Marcos Kodama. I'm from the University of São Paulo Medical School, and I will present the case related to gastric cancer. I think it's an easier case compared to the previous one. So let's move on. I will have with me in this session Professor Robert Roses from University of Pennsylvania, Professor Naruhiko Ikoma from the MD Anderson Cancer Center, and Professor Paulo Kassab from Santa Casa Medical School in São Paulo, Brazil, and Professor Ulisses Ribeiro, also from the University of São Paulo. So the case is related to a 67-year-old male patient who complained of gastric fulfillment, abdominal discomfort, and regurgitation for 3 months. He had no weight loss or abdominal pain. His previous medical history included a resection of a skin lesion 8 years ago, but without pathological report available. He was a current smoker, but he had no habit of alcohol intake. No family history of neoplasia. During physical examination, the patient had a weight of 77.6 kilograms with a BMI of 28, Karnofsky performance scale of 90, ECOG of 0. The abdominal examination and the laboratory exams were unremarkable. The patient performed an upper digestive endoscopy that demonstrated a 3-centimeter lesion located along the lesser curvature of distal entry extending to the anterior wall. The lesion was friable, covered with fibrin extended to the pylorus. However, it did allow the passage of the gastroscope to the duodenum, and the biopsy demonstrated a gastric adenocarcinoma with cyanide ring cells. So I would like to ask the panelists about how to stage this patient with CAT scan of thorax and abdomen, CAT scan plus endoscopic ultrasonography, CT scan, or CAT scan plus EUS plus laparoscopic and diagnostic laparoscopy. Professor Robert Roses, can you answer this question?
I vote for number 4.
Number 4. Do you have any other comments on that option?
Well, no, I mean, I think we're going to use EUS to provide a T classification. We're going to use CT scan to exclude metastatic disease and sometimes a pertinent positive of a pathologic regional node, and then laparoscopy. Well, I should say laparoscopy, assuming that EUS and CT bear out locally advanced disease and exclude gross metastatic disease, then laparoscopy will be especially pertinent for excluding occult metastatic peritoneal dissemination.
Professor Kasabi, do you think
Yes, for this patient, I would choose to do CT thorax and abdominal, and not to, I'm not choosing PET CT because for poorly cohesive cells, tumor is very, very bad, so it's worthless. So I would choose only CT scan for thorax and abdominal, and laparoscopy, obviously, before beginning the neoadjuvant therapy.
Okay, thank you. Professor Naruhiko, do you perform PET CT for in any situation for gastric cancer? Do you have any indication for the use of PET CT?
It's very rare. You know, like Dr. Kasab said, for signet ring cell tumors, it's very rare for them to light up on the PET CT scan, and also, you know, it's not the perfect study. The only occasion I may consider is doing the CT scan and a questionable finding, and the patient is not very healthy. I want to avoid doing the surgery, and then when I'm looking for stage 4 disease, I may order PET CT scan, but it's not part of the routine preoperative staging protocol.
Professor Ulysses, any comments?
No, we usually do the same CT scans for thorax and abdomen, and looks like that's an advanced lesion already. So I will start with that, and afterwards laparoscopy to stage gross disease in the peritoneum. We and others have showed that 20% of these cases may have peritoneal disease. So endoscopic ultrasound, we usually do it for when I think in the early lesions, and so I'll do the CT scans for thorax and abdomen. I don't think there is any advantage to MRI to stage these patients. Otherwise, this patient has some nodules, liver nodules, so we can differentiate liver lesions with MRI. If not, just CT scans of thorax and abdomen will be okay.
Okay, thank you. I think it's important to remember that just last week, the Dutch group have just published the plastic trial, they call it, like it's PET, CT, and laparoscopy for gastric cancer staging. They only demonstrate like 3% of distant lesions that were diagnosed with the PET CT, and 18% of peritoneal lesions with diagnostic laparoscopy, just as Professor Ulysses said.
Yeah.
So the patient did perform an endoscopic ultrasonography, and the exam demonstrated a lesion with fusion of all gastric layers, however, preserving the serosa. And there was the presence of a homogeneous lymph node measuring 8 per 5 millimeters close to the duodenal arc and lesser curvature. And the endoscopists concluded that it was an advanced neoplasia of distal antrum with positive lymph nodes. So the staging was T2N1 for the endoscopist. Later, the patient performed a CAT scan. I have some images of the exam. There were no sign of systemic disease. And in the distal part of the stomach, we can see the thickening of the gastric wall, however, without any signs of enlarged lymph nodes in the exam. So what the case was presented at the multidisciplinary meeting with these previous exams, and what to do next. Upfront surgery, since we did not find any lymph node metastasis during the CAT scan, perioperative chemotherapy based on the positivity lymph node on EUS, or neoadjuvant chemotherapy plus radiotherapy. I would like to start with Professor Naruhiko Hikuma regarding the indication for radiotherapy.
Yeah, the MD Anderson standardized protocol is starting with the chemotherapy. We typically use FOLFOX or 5-FU-based chemotherapy for 2 months, but we don't use FLOT. And then followed by chemoradiation therapy, we use 45 gray with 5-FU or Xeloda, and followed by surgery. But having said that, I know it is unique protocol we use at MD Anderson, so I'm not offended if I receive the patient's referral from outside facility who already got the FLOT chemotherapy. I do not necessarily add the chemoradiation therapy to follow.
Professor Robert Roses, and what about in the University of Pennsylvania?
Yeah, we're using FLOT for the majority of patients with locally advanced disease.
Professor Kasabi?
Yes, I would, but first, this is a patient that probably is T2N positive, so it's either a 2A stage or maybe a T3N positive, so it's a 3-stage clinical stage. So this patient has to undergo neoadjuvant chemotherapy. I would choose personally FLOT, but in our institution, we do not have FLOT for those patients in public service. So we choose on those patients Xelox or FOLFOX for those patients.
Professor Ulysses, do you see in private practice, do you see much difference between the patients who use FLOT compared to the others schemes has chemotherapy regimes as commented by Professor Kassab?
No, FLOT is a little bit more heavy on the patients because they feel more the nausea and vomiting, etc. So in our patients who had very bad conditions at the university hospital, is a little bit more difficult for us to do it. But in a private practice that we can have a little less advanced tumors, FLOT is a good perioperative chemotherapy to be done. I would do this patient so even mFLOT or Xelox because of the single ring cells and of this lymph node that has been diagnosed by the US. But I would ask the panelists if they change their minds based on the molecular findings of these tumors. I mean, if the patient has microsatellite instability or even other markers, if they would go to the surgery up front or perioperative chemotherapy based on the molecular markers in these tumors.
Yes, Ulysses, yes, I would, if it's high MSI, microsatellite instability high, I would not do a fluoropyrimidine scheme. So because we know that it's worse, the prognosis when you do with fluoropyrimidine schemes. So if it's MSI high, I wouldn't do it. If it's an EBV, also I would use immunotherapy for those patients. Otherwise, in genomically stable or chromosomal stability, I would do the classic you suggested before.
Dr. Rose?
Yeah, I would agree with Dr. Kassab, and although the level of evidence is not so strong, and these are post hoc analyses and smaller reports, the signal is clear, I think, that the mismatch repair deficient patients benefit little or don't benefit at all from preoperative chemotherapy. But there is some nuance. If you have a big, bulky, locally infiltrative tumor with involvement of adjacent organs, sometimes a surgery first approach is not practical either.
Yeah, let me
Great,
comment. It is a very controversial topic, and then yeah, whether we should give the chemotherapy for those MSI high tumor or not. And then I like to say evidence is very conflicting, and at least at MD Anderson we don't change our treatment protocol based on the MSI high status at this point. And the one of the reason is probably we use definitely include oxaliplatin and part of the regimen, and then we also give the radiation therapy. So those the nuances is probably different based on the treatment regimen. And then having said that, this topic needs need to be discussed and to find whether we should tailor the treatment approach for MSI status.
Okay, thank you. Let's move on. So after multidisciplinary meeting, it was decided to perform perioperative chemotherapy. We don't perform radiotherapy preoperative at our hospital. And as part of perioperative treatment, we always perform staging laparoscopy. And during the staging laparoscopy, we did not find any peritoneal implants, neither ascites, and the distal antral tumor was visualized, but without any signs of disruption of the serosa. The lymph nodes also did not demonstrate any sign of invasion, and the peritoneal cytology was negative. It was planned a perioperative chemotherapy. We do not, this case is a little bit old, and at that time we did not have a FLOT regime, and we still not have routinely for our patients. So it was planned to use mFLOX 3 cycles plus surgery. The patient completed the first 2 cycles without any major complications. And after these 3 cycles, he was submitted to a new CAT scan. The new exam demonstrated that the patient did not have, once again, any sign of systemic disease. And the primary tumor did not demonstrate any major sign of reduction. The patient still did not have any sign of enlarged lymph nodes adjacent to the tumor. So I would like to ask again the panelists about what to do next. Surgery plus D1 lymphadenectomy, since the patient don't have any sign of lymph node enlargement. Surgery plus standard D2 lymphadenectomy. Change of the chemotherapy regimes, since the patient did not demonstrate any large response during the new CT CAT scan. Add radiotherapy now, or repeat the staging laparoscopy before proceed to the surgical resection. Professor Ulysses, can you answer first now?
I'll go for B. Surgery for the D2 lymphadenectomy. Well, we believe that the D2 lymphadenectomy is the best way to do the lymphadenectomy in these patients. We agree with the Japanese who first told us and taught us about this lymphadenectomy. And I think that because of the lesion is very distal, I think we have margin to do a subtotal gastrectomy. So I'll do a subtotal gastrectomy with the D2 lymphadenectomy.
Professor Naruhiko, what's your opinion?
Yeah, so again, MD Anderson, if the patient is being treated at MD Anderson, we're gonna, the patient, we use 4 cycles of FOX, and after that, patient is supposed to get the chemoradiation therapy. But this CT scan does not provide any reason to change the plan for the treatment. So if the patient was assigned to go for the perioperative chemotherapy, patient should get surgery at this point. And I agree with the surgical plan. It's going to be subtotal distal gastrectomy and D2 lymph node dissection.
When do you consider repeating the staging laparoscopy, Professor Naruhiko?
Oh, yeah, that's a great question. And then we looked at the patient population who repeated diagnostic laparoscopy before doing the surgery, and we found the higher yield for those who had the Leonidas plastica. With the Leonidas plastica definition is not concrete, but in our definition, it needs to be diffuse type, more flat morphology, extending at least circumferentially 2/3 of the stomach. And this patient, even though it is called a signet ring cell, but I do not consider this is Linitis plastica. And I'm sorry, this is offload, but the definition of the signet ring cell, the morphology in the pathology, is not universally uniform. If the patient is being diagnosed by the Japanese pathologist, the tumor needs to be at least 50% of the power field needs to be occupied by the signet ring cell. On the other hand, in Western countries, it's only small portion needs to be signet ring cell to be qualified for the signet ring cell positive gastric cancer. So my guess is this patient does have a component of signet ring cell, but it's not classical Linitis type gastric cancer. So I do think the repeat and diagnostic laparoscopy for this case is yield is limited. So I wouldn't necessarily repeat it.
Professor Kasabi, would you consider this case for a minimally invasive approach?
Yes, I'm sorry. I completely agree with Professor Ulises Ribeiro. I would do subtotal gastrectomy and Detour lymph node dissection. The ultrasound, the endoscopic ultrasound showed small lymph nodes, smaller than 1 centimeter. But even if it's not characteristic of invaded lymph nodes, we should be aggressive on the surgery. So I think it's very important to do a very good Detour, including number 1 lymph nodes, right paracardial lymph nodes. And you could do it minimally invasive. It's the class 1 authorizes you to do, but you can do it open as well. And also regarding the histological type, the poorly cohesive, it's very aggressive and the advanced cancer. On the other hand, on the early cancers, the prognosis is better than the other. I invite you to join the International Gastric Cancer Association with the European chapter of International Gastric Cancer Association meeting on the next 19th. It's very interesting in Italy. We're going to participate remotely, but it will be a very nice discussion on the poorly cohesive cells carcinoma. So I agree with Professor Ulises to do Detour gastrectomy.
Professor Roses, would you perform it by open approach, laparoscopic, or robotic approach?
I would perform it open, but any of the above if you can do the same operation. I would say in follow-up to another comment, it's the very rare patient with Linitis that we're going to be offering a gastrectomy to, and those patients should be restaged. It's the exception rather than the rule.
Dr. Kodama, may I ask the panelists about the subtotal gastrectomy? How much proximal margin do you try to get? How much of a pouch do you think is worth leaving? Is there a role for a frozen section in this disease?
Yeah, poor differentiating or signet ring cells, we usually do 8 centimeters of margin approximately. And we do frozen sections of the margins also. But 8 centimeters is our mark.
So we do the same for poorly cohesive cells. We do 6 to 8 centimeters, and we do not routinely perform frozen sections in those very distal cases. In the body tumors, we do frozen sections, but the problem here for the resection is not only the margin. The problem is that you have very, very high incidence of number 1 lymph node metastasis. So you have to take all the lesser curvature, because the number 1 lymph nodes, when you treat it, when you take it out, you take out the vascularization of the stomach. So you have to do a poche procedure, so with a very small pouch in the upper part of the stomach.
We follow 4 or 5 centimeter margin approximately, maybe different because we use the radiation therapy. and try to leave stomach a little bit higher volume, but I don't think, larger stomach does not necessarily mean the function's better. Particularly, we do the lesser curvature lymph node dissection up the G junction, like Dr. Kasab said. And by doing that, essentially those vagus nerves are cut and the stomach is going to be just pouch. It doesn't, function. So the volume, like I said, probably 2/3 of the stomach needs to be removed. And then the small portion, even if it is just a tiny portion, I believe there's a benefit of preserving it in terms of the GI hormone production, like ghrelin, the intrinsic factor. Those function exists at the very top part of the stomach, and then there's a worth preserving it.
You do frozen section, Dr. Akoma?
Yes, sir, we do.
Yeah.
Professor Roses, any comment?
I take all of the nodes down off the lesser curvature up to the G junction. We divide the left gastric at its base, and I divide the stomach above the level of the left gastric pedicle. It's hard to save more than 1/3 of the stomach when you do that. If the tumor is higher, then sometimes you go even higher and you can preserve a remnant with a generous margin. I think that's fine.
Okay, it was decided to perform a subtotal gastrectomy with Roux-en-Y reconstruction. At that time, we did not have the results from the Chinese and Korean class trials, so it was an open procedure with Detour lymphadenectomy. Nowadays, I think this patient would be operated with minimally invasive approach. And during the surgical procedure, the gastric lesion was palpable at the distal angle without clear disruption of the serosum. This is some images of the procedure, the inferior border of the pancreas with the gastric and right gastric epiploic vessels ligated at their origin, the superior border of the pancreas with the common hepatic artery and splenic artery isolated. The final pathological specimen with the lymph node chains separated to be sent to pathology. And the final pathological report was that it was a gastric mucinous adenocarcinoma with 5 centimeters with the depth of infiltration to the serosa layer with maximum thickness of 1.5 centimeters. Lymphatic invasion was detected, free surgical margins, and the lymph node counts demonstrated 2 out of 36 lymph nodes were positive, so 2 positive lymph nodes. The pathological staging, according to TNM 2010, the old TNM stage was a PT4A PN1. So what to do next after the procedure? Complete the 6 cycles as initially planned, change the chemotherapy regime since apparently the tumor progresses during the chemotherapy, associated radiotherapy, since there is 2 positive lymph nodes, or indicate HIPEC, since it is a T4A tumor after the pathological report. Professor Kasabi, can you comment?
Yes, this patient has a very poor response to the previous chemotherapy scheme. So it wouldn't be wise to continue with the same scheme. So what I would do, I would choose for this patient to include irinotecan or docetaxel in the chemotherapy scheme, or either to do a radiotherapy together with the chemotherapy, radio and chemotherapy. So you have both choices. You can change the chemotherapy regimen or do a McDonald-like scheme with radiotherapy.
Professor Roses?
Yeah, I mean, I think this is a challenge, and there's nuance that maybe we don't get. I don't know that we're always that good at reading out response on the basis of the pathology report, and this is not so far removed from the preoperative staging. So I think if you looked at our patients who have significant residual disease, it's a little bit of a scatter what they'll get afterwards. Some of them will complete their intended preoperative treatment, and then occasionally there's some strong signal that we have to change. It's pretty rare that we would add radiation afterwards in a patient who had preoperative chemotherapy.
Professor Ulysses?
Yeah, I think the patient got the best surgical treatment that he needed. So, and we think in micrometastasis in another place. And so I will not go to the radiotherapy after the surgery, but I'll keep the cycles, chemotherapy, the same regimen, thinking in micrometastasis only. So that's the reason, the rationale maybe to going for the cycles afterwards. And I'll not change the regimen.
Professor Hikoma?
Yeah, so repeatedly said this patient has poor biology, didn't have much response. I assume that the pathologist reported the tumor regression grade, and probably it was not much, it's not much dead cell in the pathology. And then this patient will recur probably most likely in peritoneum or distally. And to me, adding the radiation therapy for the local control does not much make sense. And then whether I probably recommend a continuation chemotherapy, and then it's difficult. There's no clear answer whether we should change the chemotherapy or whether we should continue the same chemotherapy. More data needs to be accumulated to answer the question.
Dr. Kodama, can I ask a question of the group?
Yes, of course.
A throwback to an earlier point that was made, but let's say for the sake of discussion, this patient had a mismatch repair deficient tumor and had been treated with preoperative chemotherapy, now has a negligible response. Do we do anything different in the adjuvant setting?
I'll do anything else. I stop by that with the surgeon.
What about to treat micrometastatic disease? Any role for immunotherapy in the adjuvant setting?
Yes, maybe I will try to introduce immunotherapy and change. Also, I continue with the idea of changing the chemotherapy scheme for these patients. Dr. Kodama, will you reveal us the molecular type after?
No, we don't have the molecular type. We only have the molecular type related to research patients. So this was a common case. So we don't have the molecular type of this.
Yes, we don't have either. We don't have.
I think there's the great opportunity to improve this science by using the immunotherapy field. And I think there's the reasonable approach to add the immunotherapy, but I believe this type of therapy needs to be under the protocol. And as you guys know, in the esophagus and G-junction cancer, we recently published the JCO paper, New England Journal of Medicine paper, the adjuvant immunotherapy prolonged survival. So probably there's a similar role for gastric cancer patients. And also including the neoadjuvant approach, we do have the protocol to give the pembrolizumab before the surgery as long as 6 months, and for those MSI high tumor. And then again, those study needs to be continued, and the results need to be continued to be accumulated.
But do you think that this benefit will extend to distal lesions with sinus ring cells?
I'm sorry, can you repeat the question?
Do you think the benefit of immunotherapy, as you said in the publication of the New England Journal of Medicine, will also extend for distal lesions with sinus ring cells?
I think there's a potential. Yeah, I think there's a potential. The protocol we're using at MD Anderson is just giving the neoadjuvant pembrolizumab for any type of cancer, including pancreas, colon, the stomach, and any solid cancer, and has been seeing the great response to them.
Dr. Kodama, I think we better wrap up this very interesting case. I think Dr. Vote has to get home for dinner pretty soon.
Yeah.
And, so let's move on. So it was decided to keep the original scheme with mFlox, but it was a matter of big discussion in our multidisciplinary meeting. and the patient had to reduce the dose for for the last 2 cycles. And now the patient's like more than 30 months of follow-up without any evidence of recurrence. That's it. Thank you for the participation.
Thank you, Kodama.
Thank you very much.
Very nice. Very
Excellent.
nice, Dr.
Thank
Kodama.
you,
Thank
everybody.
you, everyone. Thank you, Dan. Thank you to the speakers, panelists. Congratulations. Great
Thank
session.
you, our president.
Thank you. Have a
Thank
good
you, Dr.
evening. Thank
Wagner.
you.
Thank
Thank you
Bye-bye.
very much.
so much. Have a wonderful night.
Thank you. Thanks, everybody.
Thank you very much, friends.
Same to you. Thank you. Bye-bye.